Thank you very much, sir. We'll move on to the third plenary, and it is titled Anatomy of a Disaster. And this session will be chaired by Professor Mohan Silva, who is the Emeritus Professor of Surgery at Faculty of Medicine, University of Sri Jayewardenepura. Over to you, sir.
Good afternoon. After listening to an interesting plenary on trauma care, we are entering a very important subject, a subject of anatomy of surgical disasters, a field which has become more and more important during last few decades, but it has come to the peak at the height of the COVID at present. In Sri Lanka, there is a total lockdown now. To tell us more about it, we cannot think of a better person than one of the surgical giants in the field of surgery, none other than the president of the Royal College of Surgeons of England, Professor Neil Mortensen. He's also the Professor of Surgical Gastroenterology at the University of Oxford Medical School. He's a leader, he's an academic and clinical surgeon par excellence, and on behalf of the College of Surgeons of Sri Lanka, Professor Mortensen, may I take this opportunity to thank wholeheartedly for joining us. And I was told that you were joining from a video, a pre-recorded video, and may I now request the colleague to start the video. Thank you.
Well, hello there, everybody, and thank you very much for asking me to speak at your Surgical Congress 2020. I would, of course, have liked to have told you about some of my brilliant surgical successes, but then we don't always learn from those, do we? So I'm now going to talk to you about what I've called the anatomy of a disaster, or how to cope when things go badly wrong. There was a British Medical Journal editorial in June 2018 talking about gross negligence manslaughter in healthcare. And in the UK, in the last 5 years, there has been a tendency for individual medical staff to be blamed, if you like, for serious outcomes, when in fact the system has been at fault. And it's been a subject of much discussion in the UK. Of course, we've got used to talking about complications and errors with the books by Atul Gawande and Henry Marsh's book, Do No Harm. I'd recommend it to you for a read. But of course, complications are always very painful for us, and it's difficult to manage them. And of course, the really bad ones we don't think are ever going to happen to us. And I commend to you this international bestseller, The Black Swan. And a Black Swan event described by Nassim Nicholas Taleb in 2007 is something which you just don't expect to happen. And it's those things that you can't predict: major scientific discoveries, historical events, the Berlin Wall coming down, for example, the end of communism, the internet, personal computers, disruptive technologies, and so forth. And of course, maybe this rather unexpected election of Donald Trump, and maybe his re-election this time as I speak, we still don't know. All very unexpected. And these Black Swan events come as a surprise. It has a major effect. And then afterwards, when we've had a time to think about it in hindsight, it should have been expected, much like this COVID pandemic. Now, my story is concerning this lovely man, a professor of media studies at the London School of Economics, only age 61, and his trouble started when he was giving some lectures in Mexico with recurrent diverticulitis. He had a further attack. It was really bad. His wife rang me. We were family acquaintances, and I spoke to her several times, reassuring her that all was going well. And in April 2005, he had a Hartmann's operation for perforated acute diverticulitis. He came back to London, to a famous London private clinic, and had the bowel joined together again on a Saturday afternoon. There were pain issues overnight. The ITU consultant from UCH called by and saw that he was very unwell, and he had a further laparotomy, and there was a small leak. He went to the intensive care unit at University College Hospital and was on the ventilator for 14 days. And again, because she knew me as an acquaintance, his wife rang me many days for reassurance. He eventually left hospital 30 days later, and he was off work for 3 months. And then finally, at the end of all this, his wife rang me to say, will he ever be put together again? Implying, would I do it? Well, here was the proposition. Should he ever be rejoined? He was only 61. There was no comorbidity. He was a non-smoker. He had a good long rectal stump, which would make rejoining relatively easy. He had completely recovered from these 2 major insults, and there was no obvious constitutional reason, no immunodeficiency, no diabetes or microvascular disease, which would make you think it might happen all over again. Of course, the arguments against it all were, if you don't have an operation, you don't put yourself at risk. And of course, on the previous occasion, he had nearly died. On the plus side, if he's fully informed and he understands all the risks, as do his family, and he's motivated to recover, then perhaps you should get on and do it. Well, I said yes, but conditionally. As long as the best arrangements possible could be organised to make this happen safely. It had to be in the main hospital in Oxford. He shouldn't be a private patient, but we would be managed by the whole team in the normal way. And I just discussed it all in advance with both my anaesthetist, who's head of the ITU, and an immunologist, and none of us thought there was any reason why he had a constitutional reason for failure. Well, this operation goes back to July 2026, and we put him first on an all-day list with only 2 other cases, so there was no pressure at all. The best anaesthetist, as I was saying, who was also head of the ITU. We did a laparotomy, a colostomy takedown. We mobilized the rectum. We did a stapled reanastomosis. There were good donuts. The air test was negative. And something I wouldn't normally do to make the operation as safe as possible, I made a covering stoma. Postoperatively, he was well on the first postoperative day, the second postoperative day. But on the evening of the second postoperative day, his wife rang me. She was with him on the ward to say he wasn't well and was in pain. Senior registrar reviewed him and felt that he was okay, but there was a failure of his epidural. And then what I call the gathering storm, at 10 p.m. in the evening, the senior registrar rang me to say his hemoglobin was only 7.5. He seemed to be bleeding, but there was a central line in. Intravenous blood was being given. I joined the group at his bedside very shortly, and I agreed he needed a laparotomy. He signed the consent form at 11 p.m. With me holding the form for him, and immediately had a cardiorespiratory arrest. The anaesthetist and senior registrar had gone to theatre, which was all available and already and set up, almost miraculously, because there are often delays. But because of his arrest, the house surgeon and myself resuscitated. He had an obvious aspiration. The crash team arrived. He'd been intubated. We had 23 minutes of CPR and resuscitation before we got complexes, and he was then transferred to the theatre at midnight. In the theatre, we found at laparotomy some blood, no leak on air testing, no cause for the bleeding seen despite painstaking searches, and we cleaned out all the blood, and we packed the abdominal cavity with packs, and we were going to plan to come back the following day and check that everything had stopped and everything was okay. So he clearly had bled, but probably slowly and then decompensated, but we still couldn't really tell for sure where the bleeding had come from. He developed multi-organ failure, needed multiple forms of support, and died on the morning of the 16th, 5 days after his operation. I was completely devastated. He was Jewish. He had the funeral. A few days later, I went to Jewish prayers, and in the national newspapers, there were obituaries. Here's one example in The Guardian. Professor Roger Silverstone has died aged 61 following corrective surgery, a leading pioneer of British media and communication studies. I felt terrible. 2 weeks later, we did a grand round presentation. We presented the case much as I have done to you to see what we could understand might have gone wrong and what lessons we could have learned. There was no sense in which we were covering up. This is full public disclosure in front of all the surgical teams in the University Hospital of Oxford. All went quiet until 3 months later, and then there was a coroner's inquiry. The coroner gave a narrative verdict, which is quite often the way these days, but rather suspiciously, the family had lawyers there, and I was insured with the Medical Defence Union, so we had lawyers there too. And I thought that was that, until I learned I was being sued in a civil action, some nearly 6 years later. And I think that's the first lesson in this medico-legal world. Certainly in the UK, sometimes the process can take many, many months and even years. So eventually it all came to the Royal Courts of Justice, and those of you who have visited London will be familiar with this scene. That's not my carriage arriving, but I did arrive by taxi to find lots and lots of photographers, and I wasn't really quite sure why in April the 25th, 2012 that should be happening, but of course at exactly the same time Rupert Murdoch was appearing for the Levenson inquiry about phone hacking in another part of the court. The case was that we'd carried out the surgery negligently, and that also his post-operative care was negligent. And it was obviously made worse by the fact that I kind of knew the family, and that I'd been very helping with phone calls and being understanding in the run-up to his problems in Mexico and then subsequent operation in London. Negligence is when conduct falls below the standard behaviour established by law for the protection of others against unreasonable risks of harm. And the person is acting negligently if he or she is departed from the conduct expected of a reasonably prudent person under similarly circumstances. In other words, we hadn't done all we could to stop something bad happening. So I was the defendant in a civil case. A big surprise. The trial took 8 days. The hospital had a legal team. I had a legal team. And obviously the plaintiff's team were there too. I was personally in the witness stand for 1.5 days, and 5 other medics, including the anaesthetist and head of intensive care, was also called as a witness, and some nurses too. It was a pretty stressful time for everybody. And then there was another wait. So that was in the spring, and then we had to wait till October 2012, nearly 6 months later. The barrister said that as far as English law was concerned, it could go either way, and that these sorts of cases were always unpredictable. The Honourable Justice Thirlwall was the judge who heard the case. She's now the Honourable Lady Justice of Appeal, and there I am recorded in a legal textbook. I'll not put it on my CV, for perpetuity, the case of Silverstone versus Mortensen and our trust. Not something I would have wanted, but the case was dismissed on all counts. Both the hospital and myself were found to have done our very best in. So what sort of impressions did I get from all this? I thought that my colleagues, especially the juniors, were fantastic in the dock. Everybody was very honest and very credible. For me, it was school about adrenaline and fight and flight I can tell you, I was absolutely scared stiff. You were just waiting for the opposing barrister to ask you that critical question which might trip you up in public. And the barrister who was acting for me, Edward Bishop, I've made a lifetime friend. He was extremely good. What lessons can we learn from the case? I think probably he bled from the mobilized mesorectum. If any of you out there are colorectal surgeons, be very, very careful to clean up the mesorectum after a previous resection, because sometimes the vessels cannot bleed straight away. And I think that's probably what happened in this case if you retransect any of the mesorectum. He clearly decompensated very quickly. Maybe I'd have been able to recognize things myself if I'd been there a bit sooner. I was at home only a mile or so away. I went in as soon as the senior registrar wanted me to. Maybe his past history of hiatus hernia had contributed to the aspiration, which certainly contributed to his demise. As far as the emergency teams were concerned that night, crash team was brilliant. The theatres were immediately available. There were no delays. We did our very best in the circumstances. I suppose there's a social context which we all need to ask ourselves about. Should you operate on people you know? And I think if you become prominent in your profession, inevitably you will know friends of friends or prominent people. And obviously that goes, if you like, with the position of being a senior professional in the business. However good you are, however experienced, then stuff still happens. Don't be so arrogant to think that it can't happen to you. And then, as I've said, the actual process leading up to the trial took many, many months. I had to read everything meticulously. It had an insidious, rather undermining effect, and I probably was chronically depressed about it all. If you do get into trouble, it's really, really important that you've had and built up moral capital with your colleagues. If you've been difficult with your colleagues, if you haven't joined the team, if you haven't helped the hospital do well, then they're not going to help you do well if you get into trouble. Clearly, you have to share the pain with friends and family, as I did, and I relied on many of them very, very much indeed. As I've mentioned, I had to read every single word of all the documents that came through. It felt like a fight for personal survival. Very, very visceral. Some people don't like this term second victim. I'm just going to use it briefly today because it kind of provides a way of understanding how we also, as medical professionals, go through things if there is a medical error. There's lots of evidence now to suggest there's a threefold increase in depression, there's an increase in burnout, decreased quality of life, worrying about it all, feelings of distress, guilt and shame can continue for some time. And all these effects, studies have shown, seem to occur and are regardless of career stage. So a little graph for one of those studies: loss of confidence, reduced job satisfaction, difficulty sleeping, and reputational damage. These are all the emotional impacts of medical errors on physicians. If you do any legal work, think very carefully about what opinion you give against your colleagues. I think expert witnesses need to be understanding about the tough nature of surgery and how easily things can go wrong. Unless it's really obvious, don't give the family or the plaintiff's case the oxygen of hope that something might have gone wrong and that they then want to bring it to law. And give an opinion that's contemporaneous with the time at which the allegation happened. If it happened several years previously, imagine what the times were like. Things do move on and develop very, very quickly. Things improve, and it's important to judge them by the time at which they happened. Now, the Medical Defence Union, my, if you like, insurance company in this case, at one stage said to me, "You must defend this case. We think what you've done was absolutely defendable. And if we don't defend this one, we might as well roll over and pay up for everybody who makes a case against a surgical professional like you." So in a way, I was a kind of totem for continuing and, if you like, going through the case, but it was deeply, deeply unpleasant. So what's the final lesson? The final lesson is that black swan events do happen. That even if you are a highly capable surgeon with years of experience under your belt, it can happen to you, and you need to be prepared, and you need to be able to cope with bad stuff happening. Obviously, the only way to not have bad stuff happening is not to operate in the first place. Those who don't operate don't have complications. I think if you're in a tough specialty, which is high maintenance, then you're going to have stuff happen to you. And I hope my lessons learned from this case will be useful to you as and when bad stuff happens to you in your turn, and your ability to come through it, be resilient and cope with it, and get back to surgery once more. Thank you very much for your attention. And once again, my very best wishes for a successful Congress. Thank you.
Thank you. Prof, what an inspirational speech coming from the President of the Royal College of Surgeons of England. We are extremely fortunate. I think it's really inspirational speech to all the senior and junior surgeons. And I think it will be remembered by all of us, irrespective of our level of seniority, that team matters. So whenever you have handled a complication, always think very broadly. The point I took out of that entire speech was the fact that don't make any comments without thinking, because it will one day backfire on you. On behalf of the College of Surgeons of Sri Lanka, I know that Prof is not, it's on video, but it's not there in person, but it was so great to have such an inspirational and educational speech at the hour of need for the Sri Lankan community, surgical community. Thank you very much.